Imagine being in the middle of a 12-hour shift when suddenly you find yourself facing an impossible choice: follow protocol or save a life. My name is Jennifer Hayes, and for 15 years I worked as an emergency room nurse in hospitals that tested every fiber of my being. But nothing, absolutely nothing, could have prepared me for the night when a surgeon looked me in the eyes and said he would not enter that room. The patient was dying, time was slipping through my fingers, and I was completely alone with a decision that would change everything. This is the story of how an ordinary shift became the most controversial mission of my career, and how I discovered that sometimes doing the right thing means breaking all the rules. My story begins in a place most people only dream about: Seattle, Washington. I grew up in the shadow of the Space Needle, in a middle-class neighborhood where everyone knew everyone else's business. My parents divorced when I was 12, and I watched my mother work 3 jobs to keep us afloat. She cleaned offices at night, waited tables during the day, and somehow still found time to make sure my brother and I had everything we needed. That woman taught me what real strength looked like, and it was her exhaustion, her sacrifice, that planted the first seed of what I would become. I decided to become a nurse when I was 16. My grandmother had a stroke, and I spent weeks watching the nurses at Harborview Medical Center care for her with a combination of clinical precision and genuine compassion that moved me to tears. These women and men were warriors in scrubs, and I wanted to be just like them. I enrolled in the University of Washington's nursing program and graduated at 22 with honors and mountains of student debt that would haunt me for the next decade. My personal life was always complicated. I married my college boyfriend Marcus right after graduation. He was studying to be a physical therapist, and we had this naive dream of building a life together in healthcare. But dreams crack under pressure, and ours shattered within 3 years. The long shifts, the emotional toll of losing patients, the stress of our combined debt, it all created a perfect storm. Marcus wanted children. I wanted to survive my residency. We wanted different versions of the future, and neither of us was willing to compromise. The divorce was quiet and sad, like watching a plant die slowly from neglect. After the divorce, I threw myself into work with an intensity that worried my friends. I moved from general medical surgical nursing to the emergency department at Providence Portland Medical Center. Portland became my escape, my fresh start. The city, with its bridges and rain and strange, wonderful eccentricity, felt like a place where I could reinvent myself. I rented a small apartment in the Pearl District, adopted a cat named Hemingway, and worked every shift I could get. My colleagues joked that I lived at the hospital, and honestly, they were not that far from the truth. The night everything changed started like any other Thursday in October. Portland's autumn rain hammered against the emergency room windows with that persistent northwest rhythm that becomes white noise after a while. I clocked in at 7 in the evening for the graveyard shift, 12 hours that would stretch until 7 in the morning. The ER was already chaotic when I arrived. We were short-staffed as usual. 2 nurses had called in sick, and administration had not found replacements. That meant our team of 6 was now a team of 4, trying to manage a waiting room packed with 30 patients. I tied my dark hair back into a tight ponytail, checked my stethoscope, and dove into the controlled chaos. The first few hours were a blur of IV insertions, vital sign checks, medication administrations, and the endless documentation that modern nursing demands. I treated a construction worker with a nail through his hand, a college student having a panic attack, an elderly man with chest pain that turned out to be severe heartburn, and a young mother whose toddler had swallowed a button battery. This was the rhythm of emergency nursing: unpredictable, intense, and absolutely never boring. Around 11:30 at night, everything shifted. The ambulance bay doors burst open, and paramedics rushed in, pushing a gurney at full speed. Their faces told me everything I needed to know before they said a word. This was bad. The patient was a man in his early 30s, unconscious, skin pale as paper, with visible trauma to his abdomen. The paramedics were doing compressions, and there was blood, so much blood, soaking through the sheets and dripping onto the floor in a trail that followed them into Trauma Bay 3. I ran alongside the gurney, my training kicking in automatically. The lead paramedic, a veteran named Chris, who I had worked with dozens of times, gave me the rundown in rapid-fire medical terminology. Motor vehicle accident, head-on collision, patient, was the driver, no seatbelt, steering wheel impact to the abdomen, suspected internal bleeding, blood pressure dropping, heart rate climbing, classic signs of hemorrhagic shock. They had started 2 large-bore IVs in the field and were pushing fluids, but this man was circling the drain fast. So, what do you think about what you have seen so far? Does this story resonate with you? Drop a comment and let me know your thoughts. We transferred the patient to our trauma table, and I immediately began my assessment while 2 other nurses started cutting away his clothing. His name was David Reeves, according to the wallet the police had sent with him, 32 years old. As I worked, checking his airway, breathing, and circulation, I noticed track marks on his arms, old ones, faded but unmistakable. My heart sank, not because I judged him, but because I knew what was coming. I had seen this pattern before in this hospital, in this very ER, and it never ended well. Dr. Richard Volkman was the surgical attending on call that night. He was a man in his late 50s, with silver hair, an impressive resume from Johns Hopkins, and a reputation that preceded him like a storm cloud. Some nurses respected his surgical skills. Most of us could not stand his attitude. He walked into Trauma Bay 3 with the casual confidence of someone who believed himself untouchable, glanced at the monitors, looked at David's unconscious form, and then saw what I had seen, the track marks. His expression changed instantly. It went from clinical assessment to something else, something cold and dismissive. He asked the standard questions, but his tone had shifted. Then he pulled me aside, away from the other staff, and said words I will never forget. He told me he was not going to operate on this patient, just like that. No medical justification, no clinical reasoning. He said David was a drug addict who probably caused the accident himself, that the surgery would be high risk with low chance of meaningful recovery, and that he was not going to waste hours in an operating room on someone who would likely end up right back in the ER in a few months. I stood there, stunned, trying to process what I was hearing. I told him that David was dying, that without surgery he would be dead within the hour, maybe less. Dr. Volkman looked at me with eyes that had gone flat and emotionless, and he said that was unfortunate, but not his problem. He had a policy, he explained, about high-risk patients with substance abuse histories. He would not operate unless there was clear evidence of long-term sobriety. I argued. I begged. I reminded him of his Hippocratic oath, of our duty to treat every patient regardless of their history. He told me I was being naive and emotional, that I should focus on the patients who deserved our resources. Thank you so much for staying with me this far. I promise you, the most intense part of this story is still coming. You will not believe what happens next. Dr. Volkman walked out of Trauma Bay 3, and I watched him disappear down the corridor toward the physician's lounge. He was not coming back. I stood there, surrounded by the sounds of medical equipment beeping warnings, David's blood pressure continuing to drop, his heart rate becoming irregular, and I realized with crystalline clarity that I was staring at a man who would die in front of me because someone in power had decided his life was not worth saving. That realization ignited something in me that I did not know existed, a rage so pure and focused that it burned away my fear. I looked at the monitors. Blood pressure 70/40 and falling, heart rate 130 and climbing, oxygen saturation starting to dip. David was in hypovolemic shock, bleeding internally, probably from a ruptured spleen or liver laceration, possibly both. He needed surgery, and he needed it now, but we had no surgeon. Administration would take at least 30 minutes to find and call in another surgeon, and David did not have 30 minutes. He had maybe 15 minutes before his organs started shutting down from lack of blood flow, before the damage became irreversible, even if someone did eventually operate. I made a decision that went against every rule, every protocol, every chain of command hierarchy that exists in a hospital. I decided I was going to save David Reeves myself. Not perform the surgery. I was not that delusional, but buy him time until I could get another surgeon to the hospital. I knew advanced trauma life support. I had worked in emergency departments for over a decade. I had assisted in dozens of trauma surgeries, watched procedures, learned from the best. I knew what needed to be done to stabilize him enough to survive until real help arrived. I called out to Michael and Sarah, 2 third-year residents who were on shift that night. They were young, scared, but they trusted me. I told them exactly what we were going to do. We were going to perform an emergency damage control intervention. We would transfuse blood products aggressively to maintain his pressure, prepare him for potential emergency thoracotomy if he arrested, and I was going to perform a diagnostic peritoneal lavage to confirm internal bleeding and guide our next steps. It was not surgery, but it was intervention beyond what a nurse was technically authorized to perform without a physician present. Michael looked at me like I had lost my mind, and maybe I had. He asked what would happen to us if this went wrong, if David died, if administration found out. I told him the truth. We would probably lose our jobs, possibly our licenses. But I also told him that if we did nothing, David would definitely die, and I could not live with that. Not when I knew I had the skills to at least try. Sarah, bless her heart, just nodded and started pulling supplies. She said if I was willing to risk my career, she was willing to risk hers too. That is the kind of courage you do not see celebrated in hospitals, but it exists in the quiet decisions people make in the middle of the night. We worked with synchronized precision born of desperation and determination. I began administering blood products, red blood cells, fresh frozen plasma, and platelets. Michael managed David's airway, ensuring ensuring oxygenation. Sarah documented everything meticulously because even when breaking rules, we maintained the integrity of the medical record. I prepared the peritoneal lavage, sterilizing the area, and maintaining every possible standard of care. The procedure was both terrifying and exhilarating. I made a small incision below David's navel, carefully advancing a catheter into his peritoneal cavity. When I aspirated and saw thick blood returning through the tube, my suspicions were confirmed. Massive intra-abdominal bleeding. He needed surgery immediately, but this confirmation gave me ammunition, concrete evidence that would force any reasonable surgeon to operate. Meanwhile, Sarah had already called the backup surgeon, Dr. Patricia Morrison, known for her brilliance and compassion. I continued working, adjusting transfusion rates, monitoring every change in David's vital signs. His blood pressure stabilized slightly at 90/50. Not great, but better than the terrifying numbers before. Every minute felt like an hour. I could hear my own heartbeat, feel sweat trickling down my back. Michael glanced nervously at the door, worried that Dr. Volkman would return or that the administration would discover us. The mission had truly begun. We had crossed a line of no return. I assigned duties like a field commander because that was what it had become, a battle operation in a sterile environment. But we had another problem. Head nurse Linda had noticed our prolonged time in the trauma room. I needed to keep Linda and the administrative staff distracted until Dr. Morrison arrived. I sent a technician to report a potential psychiatric emergency in the waiting room. Not a real one, just enough to divert attention. Inside the trauma room, time distorted. Seconds felt like eternities. I watched every number on every monitor with obsessive focus. My hands moved with automatic precision, adjusting IVs, administering medications. This was high-risk nursing with no safety net, and one mistake would bring everything crashing down. Michael whispered that he heard someone coming down the hallway. My heart raced. Was it Dr. Volkman returning? Security coming to remove us? I braced myself for a confrontation, but when the door opened, it wasn't an enemy, it was Dr. Morrison, still in street clothes, medical bag in hand, saying the most beautiful words I'd ever heard. "Where is my patient? And what have you done so far?" Dr. Morrison assessed David quickly and efficiently. She reviewed the peritoneal lavage results, checked the transfusion record, and examined his vital signs. Then she asked me, who made the decision to intervene without surgical authorization? I told the truth. It was my decision, mine alone. If there were consequences, they should fall on me. She nodded slowly and said something that made my eyes sting with tears. She told me I had done exactly the right thing, that my intervention had saved David's life, that he would have been dead before her arrival if we hadn't acted. But she also said, with genuine sadness, that I would face serious consequences. There would be an investigation, a disciplinary hearing, a license review. She couldn't protect me from that, but she would make sure everyone knew that my actions, though irregular, were motivated by the pure intention of saving a life. Dr. Morrison took over David's care immediately. Within 20 minutes, he was in the operating room. The surgery lasted 4 hours. She repaired a severe splenic laceration and a significant liver injury. David survived. Against all odds, despite Dr. Volkman's abandonment, despite everything that could have gone wrong, David Reeves lived. When Dr. Morrison emerged from surgery, exhausted, she found me in the break room and told me the results. I cried for the first time in years, but survival is only part of the story. The next morning, I was called into a meeting with the director of nursing, the hospital administrator, and the head of risk management. I was immediately suspended pending a full investigation. They took my badge and escorted me out of the building. The investigation was brutal. I spent 3 weeks suspended, sitting in my apartment, wondering if I had destroyed the career I had spent 15 years building. The nursing board opened its own investigation. I had to hire a lawyer I couldn't afford. My lawyer, Denise Chen, told me honestly that I was in serious trouble. Yes, my intentions were good. Yes, the patient survived, but I had violated clear protocols. During this time, something unexpected happened. David Reeves woke up and asked to meet me. His sister Michelle called me in tears, explaining that David had been clean for 8 months, on his way to a Narcotics Anonymous meeting when a drunk driver hit him. She started a social media campaign sharing David's story, emphasizing the prejudice against addicts and my role as the nurse who refused to accept that death sentence. Within days, my story was everywhere. The attention was overwhelming. Patient advocacy groups began protesting. National nursing organizations issued statements supporting me. The hospital found itself in the middle of a public relations nightmare. The hearing took place in a conference room that resembled a courtroom. Dr. Morrison testified on my behalf. Michael and Sarah explained that they participated voluntarily. David testified via video, saying he was alive because a nurse believed his life was worth saving. Then they called Dr. Volkman. Denise presented devastating documentation. In the previous 5 years, Dr. Volkman had refused to operate on 7 10 patients with histories of substance abuse. 3 died. Denise argued that my actions, while technically violations of protocol, were morally justified responses to a crisis created by the hospital's own negligence. I received an official reprimand, but kept my license. I was reinstated, although I chose not to return. The emotional toll was too great. Dr. Volkman was placed on administrative leave. The hospital implemented new policies regarding surgical refusals. Today, I work as a nurse educator, training the next generation. I teach clinical skills, but also something more important: how to be advocates for your patients, how to find courage when systems fail. David is 3 years sober. He says a nurse saved his life, and I say a patient taught me what nursing really means.